The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everybody, and welcome to another edition of Question Lab. I'm your host tonight, Jeff Downing, here to help usher you through a really special edition of QLab in collaboration with the Pharm Professor. So what I'm going to do is I'm going to introduce you to my co-host tonight, Sean Nanji. Sean, would you like to say hi to the crowd?
Well, hello, everyone. Sean Nanji here. Pleasure to be here as always. Been with RX for a little over 3 years now, working with students like you and coaches like Richard, who you'll meet later, and Boris, who's normally here, helping you on your academic journey. Also the founder of the Pharm Professor, which we'll talk about here in just a little bit. Back to you, Jeff.
Excellent. Thank you, Sean. I've got a couple of folks here to help answer questions through the question box. So Kate will be there as usual, as well as Dr. Richard Blumengold. Richard, would you like to introduce yourself to the crowd?
Thanks, Jeff. Good evening, everyone. My name is Dr. Richard Blumengold. I'm an internal medicine physician down at HCA Westside. I'm also one of the authors and co-editors of the Pharm Professor as well, and I'll be answering your questions tonight in the question box. So feel free to drop your questions as they come up.
Excellent. Thank you very much, Jeff. So before we get started, just a little background. So when I was a patient, I was given the wrong medication. This was about 10, 11 years ago. And I realized that the reason that it's happening a lot is because a lot of these, at least in my case, was, a lot of these drugs, they sound the same, they look the same. And oftentimes the way we're taught it is we're taught to memorize it, right? So we take a different approach here. We're going to teach you hopefully how to understand it and recognize patterns, which will make pharmacology a little bit easier for you. So instead of telling you what the Pharm Professor is all about, we're just going to show you here tonight with a brief lecture followed by questions. And we'll do 3 questions today. And we'll start off like we did last time we did this with an intro to the autonomic nervous system. So the autonomic nervous system is divided into 2 parts. We have the parasympathetic system and the sympathetic system. So we're going to talk about the parasympathetic system first. So the parasympathetic system is also known as the cholinergic system. Now, normally when we're doing these lectures, there's questions that I ask, and I ask students to repeat after me. So if you're in a place where you can repeat out loud, please do that. You'll get more out of it if you're learning actively. Okay. So another word for parasympathetic is cholinergic. Another word for parasympathetic is cholinergic, and cholinergic's first 4 letters are CHOL, and we'll come back to that in just a second. This parasympathetic cholinergic system, well, is responsible for rest and digest, which is the opposite of the sympathetic nervous system, which is responsible for fight or flight. So receptors in this parasympathetic cholinergic system are muscarinic receptors, and drugs work on receptors, and most of the receptors here are muscarinic receptors. And that M is key there because these receptors are your M1 receptor, your M2 receptor, your M3, your M4, your M5, okay? So we're not going to get time to talk about all those receptors today. We're going to focus on probably the most important one there, or the one that at least has the most drugs that act on it, and that receptor is the muscarinic type 3 receptor, which once again is a part of this parasympathetic cholinergic system. So let's talk more about these receptors. So we're going to specifically talk now about what happens when we stimulate these receptors, okay? So when we stimulate this muscarinic type 3 receptor in this parasympathetic cholinergic system. Now, I'm going to ask a series of questions. The answer every single time is going to be M3. So I'm hoping that if you're able to repeat after me wherever you are, you're able to go ahead and partake and actively learn with it. So which receptor can I stimulate to cause an increase in exocrine gland secretions? The answer is M3, and M stands for muscarinic, and that's in the parasympathetic cholinergic system. So if I increase secretions, is the person receiving that medication or stimulating that receptor, and are they going to be wet or dry? They're going to be wet, right? So you're gonna have these secretions increase that makes you wet, which is the opposite of anticholinergics when you block these receptors and you make patients hot and dry. That's where it comes from. It comes from this receptor. So far this M3 receptor has increased your secretions. Which receptor can I stimulate to increase gut motility? Well, that's also M3. And if you increase gut motility, are you going to have more bowel movements or less? You're going to have more bowel movements, which is why we give cholinergics to patients who have constipation and anticholinergics to people who have diarrhea. It's the opposite, right? And we'll get more into that. I know it's going a little fast, but we're going to touch on this all multiple times here. So far, this muscarinic type 3 receptor in the parasympathetic cholinergic system has increased your exocrine gland secretions. It's increased your gut motility. Now, which receptor can I stimulate to cause an increase in bladder contractions? That's also M3. And if you increase bladder contractions, will you be urinating more or less? Will you be peeing more or less? Well, think about your bladder like a balloon. If you squeeze it, that water is going to come out of that balloon. If your bladder is full of urine and you contract it, that urine is going to come out. So you will have increased urination, and it rhymes, right? M3 makes you pee. So far, M3 has increased your secretions, has increased your gut motility, and increased your bladder contractions as well. So you're leaky from everywhere. You're going number 2 and number 1, all happening as a result of this M3 receptor. Which receptor can I stimulate to cause an increase or cause bronchoconstriction? Once again, that's M3. So if you cause bronchoconstriction in a patient, will it be harder or easier for them to breathe? It'll be harder for them to breathe, which is why in patients who have asthma, we do the exact opposite. And instead of stimulating this receptor, we block this receptor with an anticholinergic. And we can't get into the anticholinergics and the cholinergics today, but I'll point you to where you can get this lecture for free here in just a little bit. So far, you've increased secretions, you've increased gut motility, you've increased bladder contractions, and you've caused bronchoconstriction, making it harder for your patient to breathe. In the eye, if you stimulate this receptor, you will also cause contraction of your pupillary sphincter as well as accommodation. And once again, that is your muscarinic type 3 receptor, which is in that parasympathetic cholinergic system. The first 4 letters of cholinergic are CHOL. Now, I want you guys to all think with me, and let's answer this question. And let's see if we can put it in the question box, okay? See if you can type in your response in the question box. There's a drug that we give for post-op urinary retention. That simply means that somebody had surgery, and now as a result of that, they have urinary retention. And now we need to help them urinate. Well, what receptor can we stimulate to cause an increase in bladder contractions and help this patient pee? What's the name of that receptor? Well, we know that receptor because it's on the screen. That's M3. So now in the question box, I want you to take a guess and let me know what 4 letters you think are in the name of that drug. We'll give all of you a few moments here to respond in the question box and let us know what 4 letters you think are in the drug that we can use in a patient that has post-op urinary retention. So we'll give you all a few moments here to type your responses in. I see 1 response so far. That's absolutely right. Okay, we see several responses coming in, and at the end of the day, I think we all know what I'm getting at here is we're getting to CHOL. We'll talk about that in a second. Now look at this. These are the side effects you're going to get as a result of any medication that's going to directly agonize these muscarinic receptors. These are the dumbbells that you see written everywhere, right? You have diarrhea because you're increasing gut motility. You have increased urination because you're contracting that bladder, right? You have meiosis, you have bradycardia, bronchospasm due to bronchoconstriction, lacrimation, salivation, and sweaty because you're wetter now. You're increasing all those secretions, right? So these will come in handy so you can figure out what the side effects will be as a result of stimulating that M3 receptor in all of these locations that you see on your screen. So drug we talked about earlier that we use to treat post-op urinary retention does in fact end in CHOL, which most of you picked up on. And the name of that drug is bethanechol. And as you can see here, it ends in CHOL. It is a cholinergic drug that's going to go to that muscarinic type 3 receptor, stimulate that bladder to contract, and help that patient void their urine, right? Now it says here resistant to anticholinesterase. We're going to talk about that in just a moment. But I hope you remember what we talked about with M3 and what side effects can occur as a result of stimulating that receptor. And with that, I will hand it off to Jeff.
Excellent. Thanks, Sean. So now it's time to apply what you've been learning. So what we're going to do, as we typically do here in Question Lab, We're going to walk you through the questions, and we're going to do it in a way that follows our methodology. Now, part of that is we cover up those answer choices when we get started. And the reason we do that is because, you're going to see a lot of things on exam day. You're going to see, you're going to see concepts and terms and drugs and pathologies and things. And some of them you're going to be comfortable with. Some of the stuff you're going to know like the back of your hand. And other things are going to be things that you might feel a little bit iffy about. And what we don't want is for you to, go through a question there, on step day, and you see something that that kind of freaks you out, and then it just kind of takes you out of your rhythm. So what we do is we cover up those answer choices. That's our first step. And our second step is we read the lead-in. Now, if you're new to USMLE-style questions or these types of assessment items, the lead-in is actually the question part. So in this case, the lead-in is which of the following adverse effects is most likely to be seen as a result of this medication. So we read that lead-in first so that it helps orient us. We get a sense of what kind of information should we be on the lookout for as we read the vignette. And the vignette is the story or the case that provides the context and the details for the question. So let's read the vignette. A 50-year-old man in the intensive care unit has been unable to pass urine since undergoing an open colectomy 3 days ago. Bedside ultrasound shows 850 milliliters of fluid in the bladder. The patient is prescribed bethanechol. So again, which of the following adverse effects is most likely to be seen as a result of this medication? Think about that. Think about how many steps you think it will take for you to solve this question. Go down to the question box. Let us know as I pass it over to Sean.
Well, thank you very much, Jeff. So, we're going to go ahead and show you what we believe is important in this STEM and the vignette. So, starting with the lead-in, right? So, we're looking for the adverse effects as a result of the medication, right? So we know that. And as we read the vignette, we know he's 50 years old. We know he's in the ICU, and he can't pass urine. Had a colectomy. We can see that he's got fluid in the bladder, and they tell us which drug that he's been given. So that's easy. So now we just got to figure out what the side effects of bethanechol are, and from that list, which is the most likely one that we're going to see. So I'm going to uncover those answer choices now, and we're going to start at E and work our way up. Okay, and we do that because we don't want you to accidentally skip an answer choice. A lot of times students will start at A and work their way down. They see something that they like and they click it without reading all of the answer choices. So we want to, help you. We want to prevent you from making any careless mistakes. So we start at E and work our way up to A. So E, sensitivity to light. D, involuntary muscle contractions. C, hypertension. B, dyspnea. And A, decreased urinary output. So with that, I'll hand it over to Jeff. He's going to open up the poll and let you submit your responses.
Okay, so we have launched the poll. Go ahead and let us know which of the following adverse effects you believe is most likely to be seen as a result of the medication given. We want to remind you that on test day, you don't want to leave any questions unanswered. You're not going to be penalized for it, so don't leave any of them blank. And definitely you don't want to leave any of them blank here during question lab. So let's see, we've got about 60% of you have voted. We've interesting here, we've got a pretty sizable lead for one of the answer options. So let's see if everybody here in the crowd is on the right track. So I'm going to go ahead and close this poll, and we'll share those results. And you'll see that over 2/3 of you selected answer choice B, dyspnea. All of the others, not too many votes. You got double-digit votes for answer choice E, sensitivity to light. So let's go ahead and hide those results, and I'll let Sean let us know what the answer is.
Well, thank you very much, Jeff. Great job, everyone. The answer is indeed B, and that's dyspnea. And we know that because we talked about that M3 receptor going into and causing bronchoconstriction. So for all of you who got it right, great job. If you didn't, don't worry about it. We'll talk through it now, right? So we talked about several things that can happen here. Let's start with E and work our way up, okay? Sensitivity to light, that's not likely to happen because what we do is we will actually stimulate the muscles in the pupillary sphincter and make it easier for you to have good vision when it comes to light. So that's not the correct answer. D, we had involuntary muscle contractions. You may see that if you were stimulating different types of receptors or if you had organophosphate poisoning, which we'll talk about in a little bit. So that's not correct. And we'll touch on that here as we get to our second question. So don't worry about it. Hypertension, you're going to see if you stimulate different receptors, not necessarily these muscarinic ones. And so one pattern you can keep in mind here is the 1-lane road and the 2-lane road, right? So the question I always ask everybody, and this is not a trick question, we'll let you respond in the question box. You have a 1-lane road and you have a 2-lane road. Which road has more room? Once again, not a trick question. Which road has more room? Please let us know in the question box, the 1-lane road or the 2-lane road, 1 or 2. What do you think? Now, sometimes medical students will overthink things and think there's a trap, but sometimes things are just visible right there on the surface. So I hope that you all are saying 2-lane road, which I see coming in. You're absolutely right, right? The 1-lane road has less room, the 2-lane road has more room. And that's how I keep my alpha and beta receptors straight, right? So if you have a 1-lane road, that's less room. So you have a name now. You have to name this 1-lane road. This 1-lane road that you told me has less room needs a name. And you can name this 1-lane road one of 2 names. You can name it vasoconstriction or vasodilation. Pick one, right? And I hope that you're going to pick vasoconstriction. And that's how I remember that alpha 1 and beta 1, 1-lane road, will cause vasoconstriction and increase your blood pressure, whereas alpha 2 and beta 2, 2-lane roads, will cause vasodilation and decrease your blood pressure. And we're not messing with your alpha or beta receptors here. So we know as a result that we're likely not going to have hypertension. Dyspnea is our correct answer. We talked about that because we're causing bronchoconstriction. And the last answer we have here is decreased urinary output. Well, that's actually the exact opposite of what's going to happen. We're giving them M3 because M3 makes you pee, and this patient is unable to do so. So that is the wrong answer for that reason. But great job, everyone. This was a question that not many people usually get right, but I'm glad that you were able to get it right after that explanation. So let's move on here and talk a little bit about indirect muscarinic agonists. So there's 2 ways to make you more muscarinic or more cholinergic. One way is to directly stimulate those muscarinic receptors. Another way is to keep acetylcholine in your system. And the way we do that is there's an enzyme, and that enzyme is called cholinesterase. And anytime you see ACE, it breaks down whatever's in front of it. So penicillin ACE breaks down penicillin. Beta-lactamase breaks down beta-lactam. Cholinesterase breaks down acetylcholine. So if you can prevent acetylcholine from being broken down, you will have more acetylcholine in your system. And if you have more acetylcholine in your system, you will be more cholinergic. And so what we can do is we can inhibit that enzyme, that cholinesterase enzyme. So if that cholinesterase enzyme is not there or not functional, it will not break down that acetylcholine, and you will have more acetylcholine, and you will be more cholinergic, and you will thereby be increasing or causing more muscarinic agonism as a result. So there's 2 ways to make you more cholinergic. One is to directly stimulate those receptors. The other one is with an anti-cholinesterase, which will, as a result, increase acetylcholine activity by inhibiting the breakdown of acetylcholine by acetylcholinesterase. So once again, those category of drugs are called anti-cholinesterases. Now, similar to cholinergic drugs, because they're also causing you to be more cholinergic, you're going to have a very similar side effect profile, which is the exact same as you saw when we talked about stimulating that M3 receptor, okay? And what they'd like to ask you is they like to say that, there was a patient that was exposed to a pesticide or organophosphates, and now they have organophosphate poisoning. And how are you going to treat it, right? So in essence, they're too cholinergic, right? So you got to make them less cholinergic. And there's two ways of doing that. And one way of doing that is by giving them a drug that will either make them more cholinergic directly, right? They're already too cholinergic. We want to make them less. We want to make them have less of these symptoms. So we got to do the opposite. So we can either make them more anticholinergic by giving them an anticholinergic, or we can stimulate the enzyme that's breaking down acetylcholine, which is cholinesterase, right? So we can ramp up that cholinesterase activity to take out some of that choline to make them less cholinergic, or we can give them an anticholinergic. Two ways to really do this, right? So with that being said, let me hand it off to Mr. Jeffrey Downing.
Okay, Sean, here we go. So let's go to question number 2, see if we can apply some of this newfound knowledge. Again, we've got all of those answer choices covered up, and we're going to start with the lead-in. Which of the following is the mechanism of the pharmacologic agent used to treat the patient's most likely diagnosis? Okay, so try to parse that, see what kind of information is going to be valuable for you as we read the vignette. A 25-year-old man is brought to the emergency department because of diarrhea and difficulty breathing. He works as a day laborer on a fruit farm. Temperature is 36.9, heart rate is 50, respiratory rate is 23, and blood pressure is 80/60. On examination, he is diaphoretic, drooling, and unable to answer questions coherently. So again, the question, which of the following is the mechanism of the pharmacologic agent used to treat the patient's most likely diagnosis? Let us know down in the question box how many steps you think it's going to take to solve this particular item as I turn it over to Sean.
Excellent. Well, let's take a look here. So first and foremost, let's see what's important here, right? So we need the mechanism of the drug that's being used to treat the most likely diagnosis. So we know he's 25 years old. He's got diarrhea and difficulty breathing. He works at a fruit farm. His heart rate is 50, respiratory rate is 23, blood pressure is low. He's diaphoretic, he's drooling, and he can't answer questions coherently. So the first thing we have to figure out is what state is this patient in, and then how can we get him into the state that's the opposite of that to get him out of the situation, right? So we got to figure out what state he's in and then how to get him out of it and what the opposite of that is and how we can accomplish that. So probably a 2-step question. So I'm going to go ahead and uncover the answer choices. Once again, we'll start at E and work our way up. This one is a little bit more challenging, but we're hoping you'll be able to follow along here. So number 1, regenerates acetylcholine esterase. D, nicotinic receptor antagonist. C, nicotinic receptor agonist. B, muscarinic receptor agonist. And A, inhibits acetylcholinesterase. So let's see here which one of these mechanisms is going to help this patient counteract their symptoms. Jeff, I'll hand it over to Jeff here.
Okay, Sean, thank you. So the poll has been launched. Go ahead and let us know which of the following is the mechanism of the pharmacologic agent used to treat the patient's most likely diagnosis. This is a challenging question, but it's not out of the realm. You will see these types of questions on test day, even for step 1. So you need to be able to work your way through these multi-step integrative questions. Okay, let's see. A little over half of you have voted, and right now it's sort of a 2-horse race. Interesting. So it seems like most of you are focused on one of 2 answer choices. So with that, let's see. Almost 3/4 of you had voted. I'll give you a few more seconds before I close the poll. As a reminder, we will have that raffle later on in the evening. We've also got a special offer for you. Okay, so we're going to close that poll and let's share the results. So almost 3 out of 5 of you went with answer choice E, regenerates acetylcholinesterase, while almost a third of you went with answer choice A, inhibits acetylcholinesterase. Okay, so with that kind of, again, a two-horse race here, let's go ahead and reveal the answer. Sean?
Well, thank you, Jeff. So 58% of you got it right? Regenerates acetylcholinesterase, and the name of that drug is palidoxime. Now, let's talk about why that's the right answer, right? So if you look at the symptom profile of this patient, it should remind you of stimulating that M3 receptor, that cholinergic side effect profile that we saw. This patient is too cholinergic, and so we have to somehow figure out a way to make them less cholinergic. So if we regenerate acetylcholinesterase, that acetylcholinesterase will break down acetylcholine and make them less cholinergic and help them get out of this situation. So that is why that's the correct answer. All right. So if you inhibit it, which is what a lot of you picked in answer choice A, if you inhibit acetylcholinesterase, you'll prevent the breakdown of acetylcholine, and you'll have more acetylcholine in the system, making that patient even more cholinergic. And that's the exact opposite of what we want. So that's why E is correct and A is incorrect. Now, as far as D and B go, we're not talking about nicotinic receptors here. This is all about being cholinergic or not cholinergic. And muscarinic receptor agonists, well, that's very similar to the mechanism of answer choice A. If you stimulate that muscarinic receptor, you're going to make that patient more cholinergic, and that's the exact opposite of what we're trying to achieve here. So the correct answer is regenerates acetylcholinesterase, because acetylcholinesterase breaks down acetylcholine, and that will help this patient get out of the cholinergic state that they are currently in. All right. So with that, great job, everyone. We're going to now move on to our last question. Before we do that, we're going to talk a little bit about heparin and warfarin. And we did this before, and whenever I teach these drugs, I always like to teach it with the alphabet, right? H comes first, heparin comes first, W for warfarin, warfarin comes later, okay? The word acute comes first, the word chronic comes later, right? So heparin is used for acute conditions, warfarin is used for chronic conditions. And if you look at the list of clinical indications here for heparin, you'll see a bunch of acute conditions, and it even says immediate anticoagulation for pulmonary embolism, acute coronary syndrome, MI, right? So these are all immediate things that we need to use heparin for. And the reason for that is because heparin has a short half-life, warfarin has a longer half-life. Heparin is used for acute conditions, warfarin is used for more chronic conditions, okay? So how does heparin work? Well, heparin binds to antithrombin 3. It decreases the formation of thrombin in factor 10A. It's got a short half-life, so it can be stopped the same day of surgery, and you can have surgery afterwards, okay? Side effects, well, if you overdose, you'll have increased bleeding. And you can also have what we call heparin-induced thrombocytopenia. So when somebody has heparin-induced thrombocytopenia, what's happening is you have decreased formation of thrombin and factor 10A. You have too much of that happening. And the way you can counteract that is by directly binding to and inhibiting thrombin with drugs like argatroban, right? Which is why we can also now give, low molecular weight heparins for patients in which HIT is a concern. So heparin and warfarin, that's the way to keep it straight. And if they do have HIT, if they're not on a low molecular weight heparin, they somehow got HIT, what you want to do is get them out of that state. And the way you get them out of it is by binding directly to and inhibiting thrombin, okay? So we're going to show you now how they like to ask questions like this. I know we're kind of walking you through it, but that's okay, because the easier, if you can learn it in an easy way and apply it, then when it's thrown at you in a harder question, you should still be able to get it right. Learning it should be easy. Testing yourself then becomes easy as well. So with that, I'm going to hand it over to Jeff for our third and last question of the evening.
Okay, everybody. So again, as Sean said, there's always quite a bit to learn, and if you find good useful ways to remember this information and chunk it out and get it to a place where you can quickly pull from it on test day, you're going to be in great shape. So let's get to our final question here. Again, we've got all of the answer choices covered up, and we'll start with the lead-in. Administration of which of the following medications is the best next step in treatment? Okay, think about that question. Think about what kind of information will be useful to you in answering it as we read the vignette. A 69-year-old man is admitted to the hospital for management of a pulmonary embolus for which he receives heparin. 5 days later, he reports bilateral leg swelling and pain. Ultrasonography reveals bilateral occlusive thrombi in the popliteal veins. Platelet count is 27,000, prothrombin time is 12 seconds, and activated partial thromboplastin time is 65 seconds. His heparin is discontinued. So again, the question, administration of which of the following medications is the best next step in treatment? Let us know in the question box how many steps you think it's going to take to solve this one as I pass it over to Sean.
Well, thank you very much, Jeff. So once again, let's take a look at what we think is important here in this vignette. So we know that we have to give some medication, and they're asking us what the best next step is in treatment, right? So a 69-year-old man has got a PE. They gave him heparin. 5 days later, bilateral leg swelling and pain, bilateral occlusive thrombi in the popliteal veins, and as you can platelet count, prothrombin, and APT here are listed, right? And it says heparin is now discontinued. So what do we do now to help treat this patient? Well, in order to know that, we need to figure out what's going on with this patient. I'm hoping that you've already caught on to what's going on here. And so now we just have to figure out in the second step what the next step in treatment is. So let's take a look at the answer choices here. We've got E, warfarin, D, vitamin K, C, protamine sulfate, B, direct thrombin inhibitor, and A, aspirin. And with that, I'll hand it back over to Jeff.
Okay, so here we go, everyone. We're going to launch the final poll tonight. Take your best shot and let us know which of these following medications, if administered, would be the best next step in treatment. Hopefully you guys are doing, overall, up to this point, you guys have done really well on the questions, but I think what's most important is that hopefully you're getting you're getting some nuggets that you'll be able to use to answer other questions, which is of the most importance here for tonight's question lab. So let's see, about 3/4 of you voted. Again, it's one of the answer choices is running away with it. There's another answer choice though that's garnered a decent share of the vote. So let's go ahead and close the poll and share the results. So what you're going to see here is that again, about 3 out of 5 of you went with answer choice B, direct thrombin inhibitor, and about 1/4 of you went with protamine sulfate, answer choice C. Again, let's hide the results, and I'll let Sean reveal the answer.
Well, thank you, Jeff. So correct answer is B, direct thrombin inhibitor, and let's talk about why that's the correct answer, right? So if you look at this vignette, it's really leading us towards heparin-induced thrombocytopenia. And that usually happens, it's rare, okay, but it's an important complication. It usually happens 5 days to 2 weeks after use heparin. So what happens is these IgG antibodies develop against this heparin-bound platelet factor, and that leads to platelet activation, more clot formation, and steadily dropping platelet levels, which we saw here in this patient, right? So this patient has HIT, and a lot of you went the heparin overdose route, which is not what's happening here, okay? Because if there was this is HIT, it's heparin-induced thrombocytopenia, because this patient has bilateral occlusive thrombi, right? If you had too much heparin, you probably wouldn't be developing a thrombus. This is a reaction they're having to that medication called HIT due to development of IgG antibodies, okay? So it's not the same as a heparin overdose. It's pretty much exactly the opposite, right? So let's start at answer choice E, warfarin. Well, warfarin is another anticoagulant, right? So if you had too much of an anticoagulant here, you probably wouldn't have developed those thrombus, and aspirin as well, right? So both of these will prevent thrombus formation, but do not have a role in treating HIT. And if you had those, these thrombi probably would not have developed. So that's not what the next step is here, and it's not what's going on. What's going on here is that this patient has HIT, and we need to, aspirin and warfarin aren't going to help with HIT. It's not the mechanism that we need to counteract here. If you put vitamin K, vitamin K is used to reverse the effects of warfarin, and we use that to, reverse that anticoagulation. Protamine sulfate is used to counter heparin overdose. So some of you were on the right track knowing that there was something wrong with this patient being on heparin, but it wasn't an overdose. If it was an overdose, then protamine sulfate would be the right answer. What happened here is this patient, they stopped. Another good clue here is that they stopped the heparin. Heparin is discontinued. Whenever you see heparin is discontinued and you see the side effect profile, immediately start thinking about HIT. And we showed you that slide earlier about drugs like ergatroban, which are direct thrombin inhibitors, okay? And what they'll do is they'll inhibit thrombin, and that will then help with the HIT because it's the exact opposite mechanism of heparin. So, direct thrombin inhibitor is the correct answer here for HIT. And, you can avoid HIT altogether in patients by doing low molecular heparins. And the good thing about those low molecular heparins is that they also end in parin, P-A-R-I-N. And so, if you learn with patterns, and, we talked about CHOL earlier, that's one pattern that's there for a lot of cholinergics. There's patterns for every type of drug. And we teach that to you in the Pharm Professor, and then we test you on it like we did today, right? We want to lead you towards the right answer and then explain it to you. And hopefully after that explanation, you'll be able to get this question right on test day, right? So if you're liking the lecture style, Jeff will show you later how you can go on and access the Pharm Professor and get a copy of it's a physical textbook that comes with lecture videos. So you sign up, we mail the book out to you, and you get access to the videos. And it's about it's about 11 hours total to learn all the Pharm that you need for step 1 and step 2. So with that, if you want to review these questions that we did today, here are the QIDs. You can simply type these into the USMLE-Rx search field, and it'll pull these questions right up. So I left this up for a while. Hopefully you've had enough time to take a screenshot or make a note of it.